Hello, can you hear me?
Yep.
Okay, perfect. Thank you. Sorry about that delay. All right, so my talk's going to be on intraop continuous renal replacement therapy for liver transplant patients during liver transplant surgery. I have no financial disclosures, and my objectives are going to be to provide an overview of the incidence and management strategies for patients with kidney dysfunction in the OR during liver transplant surgery. I want to review the fundamentals and principles of general renal replacement therapy that we use for our patients in the ICU, and the modes of which our ICU doctors can choose from different replacement therapies. I want to talk about the state of CRRT use in liver transplantations in 2020, and some of the indications from recent studies as to why it might be useful, as well as some studies that have come out recently that said large centers don't use intra-op renal replacement therapy in most, if not all, of their patients, and they don't have any increased incidence of issues per their studies. So kidney dysfunction in liver transplant patients, the incidence is increasing with time as NASH becomes more of a issue that we deal with in liver transplant surgery. And renal dysfunction is seen in 15 to 25% of patients referred for liver transplants. In the liver transplant world, the most common types of renal dysfunction are pre-renal azotemia and intrinsic renal disease, hepatorenal syndrome being the pre-renal azotemia, and intrinsic renal diseases, ATN, AIN, immunoglobulin nephropathy. And when we see a lot of these patients and they present to us for liver transplant, oftentimes we're dealing with an acute on chronic kidney dysfunction. If they're hospitalized patients, they typically are, they've been hospitalized for liver failure exacerbation, they're hypotensive, they're on antibiotics, they may have received contrast for a GI bleed, and they're ischemic on pressors. So all of these things that contribute to declining renal function acutely pre-transplant. This data is from the United Network of Organ Sharing, UNOS. It's on the x-axis. I just wanted to illustrate how the number of kidney transplants in dark blue and the number of liver transplants in light blue continue to increase on an annual basis. With that, the orange line is the percentage of combined liver kidney transplants. And as you can see, over time, since 1988 till 2020, the incidence of combined SLKs have gone up from about 2% to 9% of liver transplants a year, making, even with the changes in UNOS criteria for SLKs, it's still increasing on, it looks like it will still continue to increase on an annual basis. So this problem is only going to get worse with time. As far as current practice managements, SATA actually sent out a practice survey patterns to all their, to about 70 or so transplant centers. The directors of the liver transplants, the anesthesiologists, responded to the survey, and it wasn't just on kidney dysfunction, it was on a whole host of issues. But in their survey, they did ask for questions about practice patterns of how these centers dealt with people with needing renal replacement therapy. So the first question they asked was, does your center use intraoperative renal replacement therapy during liver transplants? And 82 out of the 66 respondents, 82% of them said, yes, we do use intraop renal replacement therapy at our centers. The next question they asked was, what is the approximate percentage of cases that since you do use renal replacement therapy, that what's the frequency of use? Still, the vast majority of centers don't use intraop renal replacement therapy on the majority of their patients. Interestingly enough, 2 centers did say that they use intraop renal replacement therapy on greater than 75% of the patients coming for transplants at their center. When asked what type of renal replacement therapy they use intraoperatively, the vast majority of respondents said CVVH. Again, interestingly, 2 centers said they used intraoperative hemodialysis intraoperatively during the actual transplant itself. And then there were some centers that said they would either use CVVH or CVVHD or HD. That was 9% of the respondents. The next question they asked was, what are the most common indications for renal replacement therapy at your center? This was a free text option that the directors could choose to fill in with free text. So I tried to summarize to the best of my abilities what the main 3 indications for renal replacement therapy at the centers were. The first and obviously the highest indication was kidney disease. And a lot of people said, well, if they're on renal replacement therapy preoperatively, we continue it in the OR. Other people said they do it for combined liver kidney transplants, hepatorenal syndrome, and then there was the typical kind of acute or chronic kidney injury problems that you would see were reasons that people would use intraoperative CVVH or renal replacement therapy. The next most common was metabolic disturbances. Centers said if the potassium was high, and they had different cutoffs at different centers for what they considered to be high potassium preoperatively, they would want to use intraop renal replacement therapy. A few centers said that high MELD patients or acute liver failure patients, portal pulmonary hypertension, and redo liver transplants were reasons that they would consider using it. And 2 other centers said it was surgeon preference. There are 6 different types of renal replacement therapies that can be used. The first is intermittent hemodialysis. Second is sustained low efficiency dialysis, which is basically intermittent hemodialysis, but slower. Intermittent hemodialysis is usually used in an outpatient setting and in basically healthy hospitalized patients. Sustained low efficiency dialysis takes about twice as long as hemodialysis. The flows are a lot less, so they require about double the time, but it is the same type of dialysis as intermittent hemodialysis. Today, we're going to be talking more about the last 4. These are continuous renal replacement therapies that the patient doesn't get a break from. Ideally, they can go 24 hours a day, 7 days a week. There are downtimes for machine filter changes and machine issues, but in general, CRRT is something that's continuous. The 4 different modes of CRRT are slow continuous ultrafiltration, and then CVVH, CVVHD, and continuous veno-veno hemodialylfiltration. I'll talk about all these modes and how they kind of build on one another. SCUF is integrated in CVVHD. There's 4 principles that drive all of renal replacement therapies. The first is hemofiltration. So hemofiltration is fluid that from blood plasma that can cross a membrane in response to a pressure gradient. So on the right-hand side, you see a semi-permeable membrane, you see blood, and then you see dialysate. If you have low flows of the blood flowing in one direction, the dialysate flowing in the other, you'll have low hemofiltration rates. Now, if you increase the flow of blood and dialysate in the opposite direction, you can increase the the pressure gradient and thereby increase hemofiltration. The next is convection. The way I like to think about convection is it's solute drag. So if you think about a river that's flowing slowly, it will drag lots of mud and rocks downstream very slowly over time. But if there was a flood, it's going to drag rocks and tons of mud down river very quickly. So the same is true in convection. As you have a large gradient of water that can cross the blood into the dialysate, you can drag a lot more solutes along with the blood into the dialysate as the flow of water across the membrane increases. The next is hemodialysis, and hemodialysis is diffusion of solutes out of the blood from a high concentration to a low concentration. So dialysate solution can be variable depending on what the provider wishes to order. It typically has sodium, chloride, magnesium, and potassium in it. We're used to either giving a 2K bath or a 4K bath. It can also have bicarb as a buffer in it. Most of these patients have a low sodium or a low serum bicarb level, so they'll need some bicarb replacement. You can set those concentrations in the dialysate to be what you want, and then you can choose to have the concentration of those particles from the blood go into the dialysate to make the patient a little bit more physiologically normal. Things that it also helps too are uremia and various toxins can cross as well. They don't cross through the fusion, but they will go down from a very high concentration in the blood into a very low concentration in the dialysate. The last principle is absorption. And absorption, I like to think of it is kind of like an N95 mask. So as you're using the semi-permeable membrane to filter the blood, you're going to have particles that stick to it over time. So as we use our N95 mask in an era of COVID, it becomes harder and harder to breathe over time. So we eventually have to replace those masks because there's lots of particles that get stuck in the filter. So absorption can be used, and various manufacturers of these filters have used absorption to try to get cytokines and other toxins to kind of adhere to interleukins, to adhere to the membranes, to take them out of the blood in the case of sepsis and other cytokine inflammatory conditions. Absorption isn't really going to be talked about too much after this point. Just to illustrate the 4 different modes of continuous renal replacement therapies we can use. SCUF, it's the simplest mode. It's hemofiltration again, and it's blood flowing out of the body through a filter, going back into the body with the filtered fluid coming out into a waste bag. This type of CRRT is generally used in patients that are volume overloaded. And their only problem, they don't have any metabolic abnormalities. They don't have any other major issues other than volume overload. So it's a way to continuously and slowly take volume off patients in the ICU without dealing with many other metabolic abnormalities. The next that we're most familiar with and Leahy uses is the principle of CVVH. So CVVH uses the principles of hemofiltration and convection to take both solutes out of the bloodstream as well as to take fluid off. Just like SCUF, it has the same setup with the addition of replacement fluid that you can add to the blood. It has to work with very high flows and of water crossing the semi-permeable membrane. So if you use CVVH in a patient, you're going to very quickly dehydrate them. So as the patient becomes more and more hemoconcentrated, there'll be less water that can flow out of the blood and into the waste products. So you have to give the patient the water that they're losing through the membranes back. And you might think that's counterintuitive, but the goal of CVVH isn't to necessarily diurese the patient or take a lot of fluid off. You can do that, but you want to use it to control metabolic abnormalities and filter out particles out of the blood. So you're using the principle of convection more. So the more water that's flowing across that membrane, the more solutes you can drag with it. And that's the point of CVH, is to drag those solutes out of the bloodstream and get it to go into the effluent. You can have the replacement fluid go in before the filter or after the filter. This becomes important more in the ICU. If you want to have a preserved filter life and keep the filter from clotting, it's better to put the replacement fluid in before the filter. However, if you want to drag more solutes out, it's better to put the replacement fluid in after the fluid. This may decrease the life of the filter somewhat, though. The next is continuous veno-veno hemodialysis. And same setup as before without the replacement fluid. And the dialysate will help drag solutes out of the blood as blood flows through the filter. The next is continuous veno-veno diafiltration. And this utilizes all the principles that we talked about before. So it really gives the provider the best method to take fluid off, to change the acid-base status of the blood, to filter out uremia or filter high levels of metabolic abnormalities out of the blood in the most quick manner. Borrowed this slide from Florian, but I think it is useful now that we're transitioning into talking about more of the kidney dysfunctions in the liver and how they affect liver transplants. Kidney dysfunction is a big deal in liver transplants because there's major hemodynamic changes in electrolyte and acid-base derangements and coagulopathies that all can occur more frequently in these patients with kidney disease. They lead to more cardiac arrhythmias and more post-reperfusion syndrome, and these all lead to complications and even death for these liver patients because of disordered kidney function. So more and more, we need to decide, how do we deal with these patients presenting to us with kidney dysfunction to prevent those things from happening. And many centers are using CRRT now in liver transplants to try to prevent those things from happening. There are no definite criteria for initiating intraoperative renal replacement therapy. There's common ones, though, and those common ones are uncontrolled metabolic acidosis, electrolyte abnormalities, volume overloaded states, and brain edema. There are risks, though, to using intraoperative renal replacement therapy. Exposure to the extracorporeal circuit, insertion of large central venous cannulas, decreased core body temperature, need for specialized personnel, and added cost. Some studies that have been done in the past have shown higher rates of graft failures, renal dysfunction, neurologic failure, and postoperative bacteremia from insertion of these lines and using them intraoperatively. Renal replacement therapy has come a long way since its inception. There's 3 types of ways that you can prevent filters from clotting using anticoagulation. The first is that you can give heparin through the CVVH before the filter. And then after the filter, you can infuse protamine to prevent that heparin that flowed through the filter through the blood from going systemic. The next is that you can use citrate. Citrate will also prevent filters from clotting, but it requires calcium to be given intravenously, as the citrate will bind your body's bloodstream, the calcium in your bloodstream, and thereby causing hypocalcemia. The third way is to not anticoagulate these patients, and when they come to us at Leahy, we don't provide them with citrate or heparin to keep them from clotting. But a lot of these detractors from renal replacement therapy like to talk about another thing that wasn't on this slide, which was increased risk of bleeding from renal replacement therapy. So there's different ways of dealing with kidney dysfunction during liver therapy. The first is a patient that's volume overloaded. With renal replacement therapy, you can just set an hourly diuresis rate that can be started preoperatively, go in the OR, and then go to the ICU. And set an hourly diuresis rate. There's several studies that have been showing that patients with much higher MELD scores on renal replacement therapy intraoperatively left with a better volume status than when they came into the OR, as compared to their cohort that wasn't giving renal replacement therapy intraoperatively with lower MELD scores that left with more of a volume overloaded state than when they came in the OR. The traditional therapy for volume overloaded is decreasing resuscitation, allowing for a little bit more blood loss if the patient's antisarctic, and diuretics if the patient has urine output. There's been some studies that have looked at cerebral edema in patients with renal failure and acute liver failure patients. And renal replacement therapy has been utilized in these patients to decrease the level of ammonia in the bloodstream. Ammonia is associated with cerebral edema. No one knows if it has a direct effect on the brain itself, or if one of its byproducts, glutamate, is causing neurologic dysfunction and brain swelling in patients. But it's been shown that if you can use CRRT preoperatively in patients with renal failure, you can improve their transplant-free 21-day survival. So it's becoming utilized in the preoperative area of liver transplants more and more. Electrolyte imbalances, there's many different ways of dealing with electrolyte imbalances, both with renal replacement therapy and also with traditional therapy and acid-base disturbances. I wanted to talk about the only randomized controlled trial that just came out in 2019. It was from Canada, and it was the only one to ever come out that was ever a randomized controlled trial. It was very small. They planned on enrolling 60 patients, but were only able to enroll 32 patients after 3 years, when they thought they could enroll 60 patients in 2. Very interestingly, with the study, the exclusion criteria talked about people with preoperative potassium levels higher than 4.5 and urine outputs less than 100 milliliters in 6 hours. So they were going to randomize people either to intraoperative CRRT or conservative therapy, conventional therapy in patients that had high MELD scores. So it was very targeted towards this population of people that the intraoperative CRRT would be useful for, but they chose to exclude patients with higher preoperative potassium levels, low urine outputs, and a preoperative pH below 7.3. So even they didn't want to include patients for randomization in their trial that had potassium levels of 5 or clearly had significant pH abnormalities. Their institutional review board didn't think it was safe for them to not provide those patients with intraoperative CRRT. They tried to look at several things. They tried to look at fluid balance, graft function, survival, And they tried to look at safety endpoints related to complications from the insertion of the lines and resource issues like filter and circuit loss. Another interesting thing about this trial is that out of the 32 patients randomized, the 17 patients that were randomized to standard of care, 7 crossed over in the OR and received intraoperative renal replacement therapy anyways. So a trial designed to answer the question about whether or not we should use intraoperative renal replacement therapy. One didn't randomize the patients, there were exclusion criteria for randomizing patients if they were deemed to be too sick to be randomized to conservative therapy. And out of the patients that were randomized to conservative therapy, 7 out of 17 of them crossed over to intraoperative renal replacement therapy anyways. They said crossover was a protocol violation except for having a high serum potassium, having a rapidly rising serum potassium with EKG evidence of cardiac dysfunction, low pH, severe hypoxemia, and very high CVP. The crossover reasons that they listed were high CVP, abdominal distension, massive transfusion, and hyperkalemia. There was no difference. It was only 32 patients, so there was no difference in survival outcomes in the per protocol or intention to treat analysis. And interestingly enough, there were 3 patients that had cardiac arrest due to hyperkalemia in the standard of care arm, and 1 patient had a massive PE in the intraoperative renal replacement group. The next trial I want to talk about is a meta-analysis that was done by a group out of China last year in 2020. They looked at some of the largest retrospective cohort trials that have been done on this question of intraoperative CRRT, and they decided that they would include 7 studies with about 1,050 patients in it. And I wanted to point out that the MELD score for those patients, if you look at the highlighted yellow area of the slide, the MELD score for the patients in these retrospective studies were much higher for the group that received the intraoperative CRRT than the MELD scores for the patients that didn't. The conclusion from this trial was that patients with CRRT required longer post-op renal replacement therapy as well. They required longer ICU stays. They required more blood products intraoperatively, but there was no difference in short-term mortality of these patients, post-op mechanical ventilation, hospital length of stay, and post-operative complications, interestingly enough. So they looked at patients with high MELD scores, significantly higher MELD scores with intraoperative CRRT as compared to patients with lower MELD scores without it. And yes, those patients are sicker. Yes, they will require longer ICU stays. Yes, they'll probably require post-operative CRRT, but they didn't have longer hospital stays. They didn't have longer short-term mortality. But goes back to having a high MELD versus a lower MELD patient. The intraoperative renal replacement therapy did not improve long-term mortality rates in patients that had intraoperative renal replacement therapy, which is probably the most important question. So this really raises some questions as to whether or not intraoperative renal replacement therapy is useful for long-term mortality, which it shouldn't be. It should be useful for short-term mortality. It should be useful for reasons such as hyperkalemic arrest in the OR and volume overloaded post-op patients having complications. I don't know if intra-op renal replacement therapy has any correlation, the ability for a high MELD patient to get through a transplant than to enable that person to live a long time. The next trial I wanted to talk about was a trial out of UCSF. this is they looked at a cohort of 785 patients that they had done over 6 years that didn't have intraoperative renal replacement therapy. Out of the 785 patients, they said that only 2 were given intraoperative renal replacement therapy. So they have the capability of doing intraoperative renal replacement therapy, but they choose not to. Their hypothesis was there was no difference in the patients that had intraoperative renal replacement therapy having differences in acidosis and hyperkalemia, that the patients that were randomized, their group of patients that had preoperative renal replacement therapy, since none of their patients had intraoperative renal replacement therapy, they looked at the patients that had preoperative renal replacement therapy at their center against those patients that didn't have preoperative renal replacement therapy as to what intraoperative metabolic conditions were in each group. And you'll see that the preoperative renal replacement therapies had higher MELD, higher INR, higher creatinine, higher GFR, and higher bilirubin. So they were much sicker than people without preoperative renal replacement therapy. One of the things they talked about was their standard anesthesia protocol. Leahy has a protocol as well for how we deal with hyperkalemia and metabolic derangements. They claim that they target potassium 4 to 4.5 prior to the anhepatic phase. They wash all of their red blood cells, or the vast majority of their blood cells, through a cell saver before administration. They use autologous cell saver. They start insulin drips on patients. They use sodium bicarb for severe metabolic derangements. They don't use THAM at all, and they use octreotide drip. They also claim they have a standardized surgical protocol that's a piggyback caval anastomosis, and that they flush the donor liver graft with heterostarch before reperfusion. The interesting part about their study was that, yes, there were significant differences between the starting pH, lactate, potassium, bicarb, and sodium in the preoperative renal replacement therapy group and the no preoperative renal replacement therapy group, that the people with preoperative renal replacement therapy had higher levels of all of those metabolites, but they weren't clinically meaningful. So if you look at the yellow portion that's highlighted, you'll notice the potassium intraoperative maximum is 4.5 for the people that didn't receive preoperative renal replacement therapy and 4.6 for the people that did. Sodium went down by 2 in the group that didn't have renal replacement therapy, and went down by 1 in the group that did. So while there were differences clinically, while there were significant differences in their metabolic status, there wasn't any really clinical, meaningful, important difference between the two groups. So in summary, should we be using intraoperative renal replacement therapy for patients? And really, the decision comes down to both the provider and institution. If your institution has the resources to do intraoperative renal replacement therapy, it's dependent on whether or not you want to, whether or not you see a clinical need for it. There's large centers in Korea, in the United States, Samsung Medical Center, UCSF, and several others don't use intraoperative renal replacement therapy. They've had very few, and according to UCSF, no reported deaths from hyperkalemia. There's some large volume centers frequently or always use it, and there's no data to conclusively show that intraoperative renal replacement therapy has decreased mortality. There are also no well-developed randomized controlled trials, nor will there ever be for this question. I think, do we have time for a couple questions? I think I went a little over.
Oh, that's quite all right. We've got plenty of time. Thank you very much for that excellent presentation and overview. The first question is, do you have any difficulty maintaining temperature with CVVH? If so, how do you mitigate it?
So I just saw a gentleman in preoperative clinic on Friday. He had a BMI of 18, and he had a very large belly full of ascites. So he's all skin and bones, and I'm looking at him. His creatinine was 1.4 on the day I met him. 2 months ago, he was in the ICU on CVVH, and I'm wondering to myself, if we take 4 or 5 liters of ascites out of him in the OR, and we do need to use renal replacement therapy on him, is he going to have a problem with hypothermia in the OR? And the answer to that question, I think, would be yes. I don't think his BMI was 18. You take a few liters off of him, his real BMI might be 15. And our renal replacement therapy, the CVVH machine doesn't have a heating element on it. And I don't think many institutions have heating elements on it. So that's questionable whether or not, if you're going to use CRRT on patients, that if you use it, you have to keep a very close eye on their temperature. And how do we mitigate it? It's very hard to mitigate it. We try to put as much of the circuit under the upper body warming blanket as we can to try to keep it somewhat warm as it goes through the machine, and as the dialysate gets put in there and the replacement fluids get put into the machine. It always comes back to the patient colder than when it went out. So if the temperature is too low, we try to raise the temperature in the room. We've never had to do this, but we could also use intra-abdominal warm saline to try to warm the patient up, because we have a lot of that available to us. But a few times when we've been using our intraoperative renal replacement therapy, we turn it off. We say, thank you, we've used it as much as we can. The patient's too cold, we need to warm them back up, and we just stop using it.
Excellent. Another question that came in, what is your preferred cannulation site for the CVVH?
So we prefer the right IJ for a dialysis catheter. We've done them in the groin before. We try not to do a subclavian for such a large line like that. Also, if they did end up needing long-term dialysis, placing a subclavian in them may have some issues for the vascular surgeons later on. So the best place we like to do it is in the right IJ, but we do it in other places. We place it in the left IJ, and we place it in the groin if we have to.
Excellent. There's one more question. It looks like, what is the incidence of renal failure requiring CRRT in transplant patients with normal pre-op renal function?
So the incidence of patients requiring it, having a CRRT post-operatively, I don't know, but I can tell you that 70% of patients have post-operative renal insufficiency post-operatively after a liver transplant surgery. I think the percentage from what I read from a few trials, maybe around 20 or 30% need it for a period of time afterwards. And I think the conversion to people that become end-stage renal disease is under 10%.
Great. Dr. Mattimore, thank you very much for your, we got a last-minute question that just came in. In the oliguric patients, do you have a creatinine cutoff trigger for starting CVVH? No, but I really think that the 6-hour rule is very helpful. Making sure that the urine output over the last 6 hours isn't prior to going to the OR is a few hundred cc's. I think 100 cc's in the last 6 hours is low, depending on the patient's body habitus. But we definitely do look at the urine output before going to the OR in patients that we're considering intraoperative CRRT for. Okay. One additional question: if we place the dialysis line in the groin, how do you manage CRRT during cross clamp? You stop and restart? So we stop. It's hard to restart it. The filter
clogs. So we would stop it at that point, and we would use it up until reperfusion. Reperfusion is until the anapatic phase. We would stop it at that point. Those are generally difficult dissections, and I think having the ability to maintain adequate electrolytes and pH during the dissection phase is going to be very helpful for us, even when we're anapatic, if we don't have it.
Great. Thank you very much, Dr. Mattimore. I'd like to thank